correlational data has what led us to trying to do this study. There are three studies I'll touch on very briefly, but these are concerns that have been mentioned in the media and seem to be substantiated in big database retrospective studies. There was an association in retrospective data between discontinuation of opioids and suicide and overdose death in a VA report published in 2018, but based on earlier data. This particular study was, I was a co-author. It controlled for more clinical covariates than most other studies, but lacked insight into why or how opioids are stopped, whether that was wanted or not, whether it was slow or fast. And it's somewhat older data. A more recent Oregon Medicaid study, Oregon has been a leader in creating regulations and restrictions that would typically induce clinicians to reduce their prescriptions. But a study from Oregon Medicaid found that suicide events, both fatal and non-fatal, were statistically correlated with stoppage. Actually, that rate of those events was higher if there was an initial dose reduction before the stoppage, which only seems, kind of surprising. And can people just confirm for me that the mode that you're seeing is the full slide?
Yeah.
Good.
Yes.
And then that's a concern, but it's a small study. Finally, within commercial Medicare data, there have been a couple of papers published that showed mental health crises were elevated after dose declines, and that the rate of these crises was elevated out to 24 months from the date of the change. But why or how those reductions occurred is unclear. So with these data, coupled with some anecdotes from the public, federal agencies have spoken. What have they said? Well, the FDA said in 2019, avoid rapid or abrupt taper. The CDC in 2022 said, avoid rapid or abrupt taper, consider the benefits and risks before making a decision to dose reduce, and consider shared decision-making. The VA's internal risk mitigation system, which is a clinical decision tool called STORM, actually has a little warning when you open it up that says the discontinuation may not make your patient safer. Those are perhaps important things to say, but they really don't say very much about suicide itself. The reason for that is the weakness of the data. Slower reductions avert acute withdrawal from opioids. We know this from care of people with dependence of any kind. However, this is not very much to do with suicide. In reports to date, slower reductions generally do not substantially reduce the risk of overdose or suicide, although those are just correlational data. But the key is, to date, we could not argue from available data that slower reductions prevent this particular outcome. And suicide is really not the ordinary result of acute withdrawal from opioid medication or even fentanyl. So we need to think about suicide in a more serious way if prevention is our goal. And we have to start with the most basic and fundamental of questions. What happened? And why?